Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegramms, Marcus at Home welcomes Dr. Swapnil Hiremath in Ottawa, Canada, with whom we would like to discuss the use of iodinated contrast media in patients with chronic kidney disease. Swapnil, it's a privilege to have you today. Thanks for taking the time.
Thanks for having me.
Dr. Hiremath is a nephrologist. He is associate professor in the Faculty of Medicine at the University of Ottawa, Ontario, and he is core member of the Nephro JC project, which is arguably the leading nephrology journal club. He has published several review papers on contrast-induced or contrast-associated nephropathy. We come back to nomenclature in a moment or two. And in this field, he has co-authored the National Consensus Guidelines in Canada. My co-moderators today are Andreas Kronbichler from Innsbruck, Austria, and Cambridge, UK, and Martin Windpessl from Wels in Austria. Before switching the mic to Andreas, I would just like to start by a patient who I just saw the other day and who nicely illustrates the problem that we are facing when discussing contrast media. So yesterday I saw an 80-year-old woman who has received a renal allograft around about 13 years ago, who has a creatinine of 2.04, and she comes with the decompensated heart failure with an ejection fraction well below 40%. And I was discussing the option with her to undergo coronary angiography. And the first thing actually she told me, no, I do not want to undergo angiography because I do not want to lose my transplant. So this illustrates why it's important to address this issue. I would like to switch the mic to Andreas.
So it's also a great pleasure to interview today. And I know you have been publishing a lot in this field. And the first thing is, of course, a bit about definition and nomenclature of contrast-induced or contrast-associated nephropathy. So in 2006, there was a New England Journal review on this topic, and they said, well, preventing nephropathy induced by contrast medium. So afterwards, contrast-induced AKI or contrast-induced nephropathy was used throughout literature. And in 2019, this has slightly changed to contrast-associated AKI, again, after New England Journal of Medicine article. So what are your feelings about nomenclature and basically these two terms? What are you using in your practice?
Yeah, so this is a really good question. The of course NEJM is the Bible, right? It's our journal which sets the standard, but they are actually lagging behind. So the CA, contrast associated AKI term, we have been using it for quite a few years. Of course, you know, when NEJM publishes it, the New England, then everyone else says, okay, this is the accepted term now. But the change, I would say, should go back to maybe a decade ago. One of the first papers that pushed back against contrast being bad was from Bruce et al. And they looked at the frequency of change in creatinine. And they showed there very marvelously that even in patients who did not receive contrast, you often see AKI. And the problem with the literature until now has been the use of administrative database. So if we go back to, you know, the 1950s and later, contrast, there was a paper in the American Journal of Medicine from Susan Hu, which said that contrast is the third most common cause of AKI. And if you go even now, people, that is the first line in many papers, right? Contrast is the third most common cause of AKI, and it's wrong. So that is from an era when we used high osmolar contrast dye. And that case series, it's a case series of less than 100 patients, of whom like 19 patients had contrast. So it's very, very small data point to use for this kind of generalization. Let's look back, you know, so we used to use high osmolar contrast dye. Now we have shifted to low osmolar contrast dye. At that time, we did not even do GFR measurement, right? It was based on creatinine, and we know how poor creatinine is at making you assess what is the kidney function. So a lot of things have changed since. We have become much safer in using contrast. So the actual risk has gone down. At that time, you know, in 4 or 5 decades ago, it was important because people did not know. So to increase the awareness, though, that kind of literature was very useful. Perhaps cardiologists were, giving contrast to anybody. We are not like that anymore. We are so judicious. So the example that Gunnar mentioned is the other way, right? The pendulum has swung the other way. People are afraid to use contrast. And that led to this movement of labeling it from contrast-induced to contrast-associated, to show that, it's not always the contrast which is causing the AKI. If you're looking at administrative data, you cannot make the causation clear. All you have is, some electronic health record or a database where you can see the CT scan or the angiogram, and you have some creatinine measurements. Whether the CT scan caused the AKI or not, it's a clinical diagnosis that is often not made properly. So all that literature is, they falsely labeled it as contrast-induced AKI, and I like this push to make it contrast associated, which takes the causation element out of it, right? So AKI happened, contrast happened. Let's figure out, if you see the patient, whether contrast was really to blame. But of course, contrast associated doesn't mean contrast induced. Some people also use post contrast, like PC AKI. That's the other term. It has not caught on as much as CA AKI, of course, but that's also a chronological. It just tells you contrast was given, AKI happened afterwards. There is no link of association or induction involved there.
So excellent. So you took away a lot of questions we have prepared already with your first statement. That's awesome. So the next one is basically a bit more complex, I think. The KDIGO AKI criteria define AKI by an increase of serum creatinine of 0.3 milligrams per deciliter, or by 50% increase, so AKI grade 1. But then you have, for instance, Preserve as a trial, and they define AKI in their trial as an increase by 0.5 milligrams per deciliter, or a 25% decline in renal function. I mean, this is quite arbitrary, and is of course outside what we are using usually. But our question is clearly, if you have a patient with CKD4 or CKD5 undergoing angiography, for instance, there is a lot of fluctuation in their serum creatinine, which is naturally the cause. How do you approach such a patient? Do you define that as CA AKI, or do you just say, well, this might have been just a natural cause of fluctuation?
Exactly. So that's, again, if you go back to the definitions aspect, the KDIGO definition, it follows the AKI network, the AKIN, and AKIN followed rifle. But the classical CIN definitions actually predate all this. So in some respects, this was the field where the AKI definitions first arose. So the 25% or 44 micromole or 0.5 milligram per deciliter, it was the classical CIN definition that was used for a couple of decades perhaps. And it was made up, right? So it was probably a bunch of cardiologists came together and said, hey, let's call this AKI. And all the literature until all these definitions became standardized are mostly of that. So the decision from Preserve, I guess, was, probably to give the traditional CIN folks something they are familiar with. But is it really clinically useful to have this 25% rise in creatinine? You're so right that if someone's creatinine is high, someone with a creatinine of 2, it goes up to 2.5, and then a few days later it goes down to 2.3. Is that clinically meaningful? So there are many different ways of looking at this. There are a lot of epidemiological studies, from Matt James from Calgary and many other places. They show that any rise in creatinine is a signal, right? It is giving you some information, and it is associated with bad outcomes in the future. Again, this is large observational data sets, not just contrast in any setting. But does that really mean that the contrast is to blame or what have you? What that is actually identifying, in my opinion, is these are patients who are at high risk of having cardiovascular outcomes anyways, right? It's showing that there is something in the protoplasm, something in the risk factors, whether they have heart failure, they have heart disease, they have vascular disease, they are going to have bad things happening later on. And that's all this is identifying, that, that blip in creatinine. If you look at Steve Koka and others have done a very nice systematic review. What they looked at in JSN a few years ago, they looked at trials. They looked at, say, trials that prevented this small rise in creatinine. Did they also show a subsequent decrease in MI, in mortality, in cardiovascular outcomes, and they did not. So what they showed is that if you look at randomized controlled trials, not at epidemiological data, not at observational data, if you look at randomized controlled trials, reducing this blip in creatinine, this softer AKI outcomes, does not actually decrease longer term clinical outcomes that matter. So they have prognostic significance, but trying to prevent them doesn't seem to help. And the last point I'll make on this is also Preserve had a sub-study of biomarkers, and this is really fascinating. It was from Chirag Parikh and others who are at Hopkins now, and they looked at tubular injury biomarkers in Preserve. It was a sub-study, so about 800 patients, not the full 5,000. And what they showed is that in the patients who did have this contrast-associated AKI, defined in many different ways, there was not really an increase in biomarkers. So the biomarkers did not correlate with this number going up and down. And again, the way I would explain that is to say that it is representing perhaps hemodynamics, perhaps something else. But this contrast-associated AKI, which is such a soft definition of a change in creatinine, it doesn't really reflect kidney injury. It's whatever you want to say, whether it's noise. Often I suspect a bunch of it is noise, and a bunch of it is change in volume status. Some of it is all the other AKI that is happening. So the definitions really matter. JC Wels and I put together, it came out of a Twitter discussion. We put together some criteria, and they're not validated criteria. It's not like the Banff criteria or the Ann Arbor criteria or anything like that. We put together some clinical criteria, and I think they are more useful when you're making a diagnosis of AKI. Is that sort of like the infective endocarditis criteria, right? Where you have essential, major criteria, minor criteria. Because the CIN or the CAAKI literature always says that you call something as CIAKI after ruling out a bunch of other diagnoses. But people pay lip service to that. They don't really follow through. And database studies cannot do that. So the patient who got contrast because they had abdominal sepsis, intra-abdominal sepsis, maybe the AKI was because of the sepsis, and the contrast is just it's a red herring. It's like a smoking gun, but actually it did not cause the injury that happened. So those kind of criteria would be useful to make sure you're explicitly ruling out patients who have a different cause of AKI. And I would argue that the clinical AKI, right, like either stage 2 or perhaps stage 3, is really more important. Should we really bother about these noisy, creatinines going up and down? They're really good for research, right? When you're doing a research study, you want events. So if I'm doing a trial, if I use the stage 1 AKI or the 25%, I will get a lot of events. So my study will be powered. But for a clinically important, when you have a patient in front of you, it's just noise.
You're also taking away my next question, basically. So this was, how would you explain the damage attributable to contrast dye, if any? Because the clear association with biomarkers of kidney failure like KIM1 was clearly not shown so far.
Yeah. So if you look at some of the older literature, again, that's with the high osmolar contrast dye. There are some animal studies. It's not great. Again, I'm not a mechanistic guy. I've mostly done systematic reviews, critical appraisal, and I'm talking about here as a clinician who sees patients getting contrast and who wants my patients to receive contrast and get the investigations they need. But if you look at the mechanistic studies with high osmolar contrast animal study, they do show some of those things, saying there is vasoconstriction, there is possibly hypoxic injury that happens. But if you look at the diagrams, they will have arrows going in all sorts of directions, hypoxia, reactive oxygen species, all those things are thrown in there. But to me, that doesn't explain the pathophysiology well. If you look at the contrast, it's colorless when you look at it, but it's viscous, right? It is even the low osmolar contrast is 600. It is roughly 600 milliosmoles. It is higher than serum osmolality. And the iodixanol, which is the isoosmolar, it's also more viscous. So these things are viscous, and they go into the glomeruli and they get filtered. And as they are going through the tubule, they are not getting reabsorbed. Water is getting reabsorbed. They get concentrated. So they get concentrated, and they make the tubular flow sluggish. That's one way to think about it. The same thing happens in the vasa recta, right? Whatever is not getting filtered is going into your efferent arteriole, and it's going through the medulla where there is possibly some ischemia happening. And the classic images I have is, if you have a patient where you're thinking of they have CI, AKI, you do a plain CT or a plain X-ray, you will often see a nephrogram where the contrast, a day later or 2 days later, the contrast is still in the kidneys. It hasn't gone. And that's sort of the logic. I like that image of having contrast, which is stuck in the kidney. Because the true CI, AKI that I have seen, often they become oliguric in a day or two, within a day or two. Creatinine goes up very fast, and then they suddenly start making urine a few days later, and they recover. So if you see that time course, right, in a week or maybe in 2 weeks, they have recovered. It is very fast, right? So they develop AKI very fast and they recover pretty fast. So if you're talking about acute tubular necrosis and the tubules healing, this course seems a little bit too fast for that. It's almost like, like a classical obstruction, but I would say it's an intratubular obstruction that is happening, which is causing, the kidney function to worsen and improve so fast. But that's, again, there are some papers which describe this. I like one by Pontus Persson, which from Scandinavia, from Sweden, I think he describes this. But the other papers you will see, they talk about, this reactive oxygen species and tubular necrosis, which is harder for me to believe. So I'm not sure, to be honest, that there is true tubular injury, even in the small subset of true contrast-induced AKI, right? It's probably this kind of stuff that is happening. Which also helps us visualize why volume expansion might be helpful, and all those interventions might be helpful. You're trying to take that away. You're trying to improve the flow through the tubules that might be happening.
So the next question is a bit tricky as well. I'm sorry for that, but as academic nephrologist, of course, we're always interested in randomized controlled trial. And how would your perfect clinical trial would look like to disprove the existence of CA-AKI? Yeah,
so if you have to prove or disprove, it's sort of like the black swan, right? When people say it's a myth, the pendulum is swinging right from one end to the other, and I think we have to be careful about how we deal with this. When people called it as being the third most common cause of AKI, that was wrong. That is wrong. That is clearly wrong. And like Gunnar's patient, we should push against that philosophy, because that leads to renalism, right? Where there's a lot of therapeutic nihilism, right? You have CKD, you don't get a coronary angiogram. No PCI for you. We don't want that either. At the other end, you see especially in the emergency medicine and critical care people, they are like, oh, it doesn't exist. It's a myth. So I think we have to be careful not to go to that end, because I'm sure as a practicing clinician, you have seen a patient who had true CI-AKI, right? And it is uncommon. I agree, I don't see it every month even. But once in a while, especially when someone gets a large contrast load and so on, you will see a CI-AKI. So like a black swan, how do you prove that a black swan exists is when you make one diagnosis of true CI-AKI. That's all you need to say that it exists. But to get to your question more about how do you establish that, it would be nice to have some kind of a randomized controlled trial where some patients are getting a contrast scan and some patients are not getting a contrast scan. But I would say the risk is so low. You have to look at what is the purpose. As an academic, yes, you want to know, does it truly exist? But as a practicing doctor, the risk is so low that kind of a trial, I think, would you would need thousands of patients to do that kind of a trial. And then you also have to think the contrast is being given for a reason, right? You're not doing it for fun. It's not like you're giving them N-acetylcysteine or something, which is almost a placebo. So the contrast is giving you clinical information. So if you're randomizing a patient to getting contrast versus not getting contrast, some patients you will have some diagnostic information you will get in the contrast group, and you will miss that information in the placebo group also, right? So it's a little bit tricky to do a true randomized blinded control trial to establish the incidence. And I would say it is so low that I would hesitate to go down that path at all. The kind of trials that have done, for example, have been, there are some nice smallish trials, few hundred patients of IV versus intra-arterial, right? Where some people got a CT angiogram and some people got a real angiogram, and they show that there is a difference, and we can talk later about what makes that. But to establish this, I think I'm not sure it is worthwhile. Academically, it would be really cool, but I can't imagine putting patients through this kind of a study where there is the care may not be the right care they may receive.
Absolutely brilliant answer. I certainly agree with that. So the next one is about incidence and reported incidents, and I'm just pointing out my two favorite clinical trials basically in this field, Amazing and Preserve. Randomizing basically the same patient cohorts, but Amazing, like 50% only had intra-arterial contrast dye, and in Preserve, I think 100%. And how do you explain between these trials the difference in CA-AKI of around 2.5 in Amazing and over 8% in Preserve?
Right, and you pointed out, it was not intra-arterial, totally intra-arterial. Preserve was completely intra-arterial, whereas Amazing, it was roughly half and half who got interventional and not. I would think the way I would explain that is probably that same thing, that it was, and Steve Weisbord, who led Preserve, he says that, even Amazing was low risk. I don't think it was low risk, it was intermediate risk. Perhaps it was, as not as high risk as Preserve was. So this boils down to the question of, and again, this is not going into whether it was CI-AKI or CA-AKI. I'm pretty sure most of it was, not really contrast induced, but leave that apart. The question I would frame it as, is arterial contrast worse than venous contrast? And I suspect that would explain most of the differences that you see here. Now, why would it be worse? People have said that, venous contrast here, it's going into the veins, then it's going into the right side of the heart, and then the left side, and then it is reaching the kidneys. By the time it reaches the kidneys, it's been diluted, and you don't get like a big load directly entering the kidneys. On the other hand, but if you look at coronary angiography, that's also into the coronary arteries. It's not into the left ventricle. So unless you're doing an aortogram or a left ventriculogram, where yes, the contrast is reaching the kidney at possibly a higher concentration, then I accept that argument as arterial contrast, perhaps a higher concentration reaching the kidney and clogging up the tubules like I was talking about. And what about infrarenal arterial contrast, right? Peripheral angiograms. Maybe they are more like venous contrast when you're talking about the, how it reaches the kidney. So there is that aspect. But I think all this is just a red herring. It's just misleading. I suspect the true reason why arterial is different than venous is because you're putting in a wire, often through the femoral artery and going in, through the aorta. And most patients who are having an angiogram have atherosclerosis. So you're going with a wire through atherosclerotic aorta, and you're going to cause some atheroembolic, phenomena that is happening. And that probably explains a large chunk of why, arterial contrast is different than venous, and why, Amazing had lower than Preserve. There are trials of radial route versus femoral route. For a TAVI or for coronary procedures, and they do show lower rates with radial compared to femoral. And again, cardiologists will have all sorts of explanations for why AKI is lower if you go through radial, like radial first, and all those proponents. But I think a big chunk of that is also because when you're going through the radial route, you are not going to go next to the kidney and dislodge some emboli which will be going to the kidneys. There is another cool study from Japan, which looked at atheroma volume, before a TAVI. So if someone's having a transcatheter aortic valve implantation, they often have CT scans before they have the procedure. So in that study, they looked at atheroma volume and AKI, and they showed that the atheroma volume above the kidney, above the renal arteries, was a greater predictor of AKI than atheroma volume below the kidney. Again, it goes back to the same phenomenon, the same explanation, that a bunch of the AKI in all these studies is not really contrast induced. it is something else, and I think atheromembolic disease is one of the big, missing explanation for all this that is going on.
Well, thank you. I think we can agree that the risk of contrast has been exaggerated for many years, but it's certainly not zero. And what can we do to minimize this residual risk for high-risk patients? And I would like to discuss some strategies to mitigate this risk in the light of modern studies. And I think perhaps we should start with acetylcysteine, which has been in the center of interest for almost 2 decades, since the TEPL study in New England 2000 with about 80 patients, CKD3, and a follow-up of 6 days. And this was a positive study, meaning that it showed some benefit change in creatinine at day 6. The much larger trial, ACT, in the Brazilian trial, was negative, and PRESERVE, of course, was negative as well. So to come to my question, do you still use N-acetylcysteine for high-risk patients? Because you could argue they have not really been involved in even the larger, more modern trial.
Yes. So N-acetylcysteine, I mean, it's such a fascinating the last 2 decades have been, for N-acetylcysteine, especially as somebody who does knowledge synthesis, this whole body of literature is extremely fascinating. I think we have been misled, to cut it short, but it's still, so the story is so interesting. If you look at why N-acetylcysteine was used, so it is a glutathione precursor. It can, donate the sulfhydryl group, helps in glutathione regeneration. So if you believe in the reactive oxygen species element of the etiology of CIN, then yes, it makes sense. On the other hand, it is poorly bioavailable. If you take oral N-acetylcysteine, not all of it gets absorbed. So maybe a higher dose is needed. There are some studies with intravenous NAC as well. But if you believe in the other theory that I tried to push for why contrast causes AKI, then N-acetylcysteine would not make any sense. There are about roughly 100 trials that have happened. If you look at it completely, 102 the last time I checked, and there are about 35 meta-analysis. So people have made their careers on N-acetylcysteine, including me, with a couple of those studies. We could have stopped much earlier, right? As you rightly pointed out, ACT, was probably should have been the final act, but it wasn't. People required a New England study. So, PRESERVE hopefully was the final nail in the NAC coffin. A lot of people have asked the same question as you have, that it's a low risk, right? It doesn't cause any harm. What's the problem in giving NAC? I would argue that it never worked, right? And a bunch of the studies that were done initially were flawed. So if you look at all those studies which were positive, and there are 4 which are strongly positive, a bunch of them are, sort of somewhere in the middle. They are all using that creatinine change as an outcome. If you look at clinical outcomes, if you look at, need for dialysis, mortality, hospitalization, there is nothing. There is absolutely no signal of benefit in any of those studies. It's like, a relative risk of close to 1. So then you step back and say, what is going on there? What is going on with this change in creatinine? There is a very nice meta-analysis from Denise Gonzalez in Biomed Central a few years ago. This was even before ACT came out. And because there's a lot of heterogeneity, right? When you're doing a meta-analysis, when you have a bunch of positive studies, a bunch of negative studies, there is a lot of statistical heterogeneity. So how do you make sense of it? And most people just do, I use random effects, and this is the relative risk. It's often showing a benefit, because if some studies are neutral and some studies are showing benefit, it is going to push your summary risk ratio to benefit, which I think is not the right thing to do. You should try to solve the heterogeneity. As a meta-analyst, you're trying to tell a story, and what is the story here? So they tried to solve this, and they showed that a few studies which showed this change in creatinine were influencing and were causing this heterogeneity. And then if you step even further, when you look at those studies, what happened, and this is seen even in TEPL study, is that what you expect if something is beneficial is that you will see that In the control group, a few patients will develop AKI. And in the NAC group, if it's really beneficial, fewer people will develop AKI. But what you actually saw was that in the NAC group, the creatinine actually decreased. So the kidney function improved, which was very, at that time it was missed. I know maybe perhaps some smart people did see it. I missed it for sure. A few years later, there was a nice study by Hoffman in JSN from Germany, and they gave NAC to healthy controls, no contrast, no nothing. And they measured creatinine, and they showed that the creatinine was lower in these patients. Now, again, this was not, it did not make a splash. There were a few other studies which showed, oh, yes, it does, but maybe it does not decrease creatinine. But I think the missing piece here is how do you measure creatinine? Because some people obviously found a benefit and some did not, right? So we measure creatinine by the Jaffe reaction is one way, which is, a colorimetric method. The other one is the enzymatic assay. And one of the reactions in the enzymatic is oxidation. And remember, N-acetylcysteine is an antioxidant. So at a certain concentration, if you add N-acetylcysteine, and we did this, there's another group which did this, and we also did this. What we did is we took test tubes and we put in NAC and we measured creatinine. With Jaffe, there is no change. But with enzymatic, the creatinine is lower. Now, again, when I add NAC to a test tube, it's a high concentration. When you eat NAC, it's going to be a very low concentration. But what I think is explaining some of this heterogeneity is that NAC creates an artifactual lowering in creatinine. It doesn't have any benefit when it comes to protecting the kidneys. And modern, again, that's why you see this disconnect, right? Where some studies show a decrease in creatinine, but when it comes to clinical outcomes, dialysis and so on, there is nothing at all. So I hope that I know this is a very long-winded answer, but the whole NAC thing is a study. It just tells you how we have been misled, right? We never had a good mechanism of the cause of CIN. We didn't have a good mechanism for how N-acetylcysteine would be beneficial. It reminds me of all this, recent hydroxychloroquine, ivermectin stuff. There is some vague theories out there. Oh, it's an antioxidant, it should work. And it showed a dramatic benefit. And everyone started using it. So we should be a little bit more skeptical of this whole literature. And I think it's fine to do the first trial, surrogate outcome, small study, it's fine. But instead of doing more small studies, I think a lesson for us is that after that first small study, which shows a benefit, we should move on and do a large trial with clinical outcomes rather than, start using something directly or keep doing small studies with misleading meta-analysis.
Thank you. That's a very important point. And my major issue with this compound was always that it often resulted in disregard of other risk factors, like we have prescribed NAC, so let's give contrast the next day without looking at blood pressure or what have you, or blood sugar. Perhaps you should move on to volume expansion, meaning hydration. And you have already mentioned the amazing trials which randomized patients to either IV fluids or no fluids, and surprisingly, no difference was found. And you have already explained the mechanism basically to generate good urine flow and thereby lessening tubular exposure to toxic dye. There was a very nice image in last year's Lancet illustrating the nephrogram, as you said. And this seems to be quite fancy in cardiology, where renal guard is used and similar systems where you give fluid to patients, they get a Foley catheter, and basically the amount of urine is matched by IV fluids with an additional stimulus with diuretics to generate this high urinary flow rates. What do you think of this approach, which is quite cumbersome in my view?
Exactly. And the first point you made is so true that this happened locally as well, right? People would be like, oh, let's use NAC and give the contrast. I've heard that many times in the last 2 decades. It's like this gives a false sense of security that you're actually doing something when you're not doing something. And it also takes away from possibly other interventions which may be useful. So let's consider it one step at a time. Is hydration even helpful? So before the amazing trial, we really did not have a good trial People talked about Rick Solomon's trial, which was in New England a couple of decades ago, and that was not saline versus nothing. It was mannitol and furosemide and saline with mannitol, right? So it wasn't really, there was no arm which was no IV fluids. Amazing was the first large trial which had a no IV fluid arm. There had been smaller trials before that, and it was a non-inferiority design, and it clearly showed that in the intermediate risk patients, with a GFR more than 30, there is nothing. There is absolutely no benefit. In fact, they did not have a large number of events, and they had to stop the trial because before they got the event rate, because the risk of AKI is so low that what are you going to achieve in these patients? This was also followed by another Dutch trial. We have to commend the Dutch groups, right? Because it wasn't just amazing. They also did the COMPASS trial. And in COMPASS, they had IV contrast, of course, but they used the bicarb, right? If you believe amazing was saline versus nothing, in COMPASS, it was the bicarb protocol that we can talk about later. But it was, again, IV sodium bicarbonate versus nothing, and about 450 odd patients with nothing, no benefit at all. So now we have two large trials showing, compared to nothing, volume expansion is not beneficial. And I think that is sufficient for me to say that in anyone with a GFR of greater than 30, that doing nothing is acceptable. And that's where we have changed and moved to. The question is, what do we do when the GFR is less than 30, right? So that is still an open question. I would love if someone funded me or you to do that kind of a large trial. And this is where, it's possible that we will get enough events to make this possible, to do a trial of this nature. It is hard not to do anything, right? If I have a patient like Gunnar's patient with a kidney transplant and someone with a GFR of less than 30, it is hard to say, oh, get the contrast and, we won't do anything. It is really difficult. So my default still is to do some kind of volume expansion. If it is possible. Now with intra-arterial contrast, if it's going cardiac cath or whatever, it's easy to arrange for the intravenous, you give some fluids before and a little bit of fluids after, whichever is your, flavor of solutions to give. It's harder when it is a CT scan. If I'm doing a CT scan, a contrast enhanced CT scan in a GFR of 25, I don't know about you, I don't have the resources to have intravenous, to have a suite where I can easily give intravenous fluids. Sometimes we fight in the hospital and arrange those logistics, but it's not always possible. There are some small studies showing that oral salt and water might be just as good. So again, these are small studies. We have done a small systematic review. It's like, a few hundred patients. The number of events are less than 100, even if you combine all of them. But they seem to suggest that it's probably similar. And in those patients, what we do suggest is, have some chicken soup before and after, or drink a few glasses of water, or eat some salty stuff, which is our poor man's version of the volume expansion, which brings to the expensive solutions, right? The renal guard stuff, and it reminds you of like the Internet of Things, right? When you have a refrigerator and you have an app which tells you what is inside the refrigerator, when you might as well go and open the door and see what is inside. Some of these technologies are there, as in nephrology, we do a lot of technology, right? Dialysis, CRRT, it's a lot of fun. I love technology, but renal guard, you measure the urine output, and on that basis, you need to have a Foley to measure the urine output. You have to have an indwelling urinary catheter, and you give Lasix and IV fluids based on that. It seems like a very expensive and complicated solution to a very simple problem. We don't use it. I would not recommend going down that path. Some people who like fancy toys may want to use it. If I have a really, really high risk patient, I would be aggressive in volume expansion. There are some other studies, right? Apart from the renal guard, there is the Poseidon trial. In the Poseidon trial, Sam Brar and others from Kaiser Permanente, they looked at measuring LV-EDP while doing cardiac cath. And on that basis, they gave IV fluids. And if you look at renal guard and if you look at Poseidon, what is common is that it allows you to give more volume and somehow safely. Our risk when we are giving more volume is, your patient already has congestive heart failure, they have CKD, and you're worried about giving them volume because they may end up with pulmonary edema. So all these kind of measurements, fancy measurements, LASIKs, they allow you to push through more volume, and it makes the number better. That's all you're really getting. If you want to do that, then yeah, go ahead. But I don't know about your feelings about it, but I would agree, what you mentioned earlier, that it seems like a, very fancy technological solution to I'm not sure a problem that that needs to be solved. But I really hope someone does, maybe the Dutch are doing it, but someone does the IV hydration versus nothing trial in GFR less than 30.
Well, IV versus oral would be nice as well, but
or IV versus oral, exactly.
The video on the Renal Guard homepage is quite convincing if you look at it. Obviously, there's loads of references they can kind of cite to make their point of the toxicity of the dye, which is nicely animated. So obviously there's a commercial interest as well, goes without saying. I think an important point is that patients at highest risk for contrast-induced kidney injury are also prone to volume overload, and one needs to be careful not to give too much fluids, which holds also true for all sorts of acute kidney injury. If we think of surgical patients who have oliguria and their weight increases from day to day, and on day 4 also you get your phone call because the patient has a creatinine of 4. So what kind of volume would you feel comfortable with? Like, I personally use half a liter prior to the procedure and half a liter afterwards, something like this.
Yeah, that's exactly what I do as well. The older literature used to give overnight IV fluid. I think the Merton was the trial which looked at bicarb. And I think, forget the bicarb aspect of it. But the cool aspect of that study was they gave 3 mils per kg for an hour before and 1 mil per kg for, 4-6 hours later. So they compressed it into something that is feasible for us to give in a daycare setting without admitting the patient overnight. And that's exactly what I do. We roughly give, a half a liter or so, few hundred mils before and few hundred mils stretched out afterwards for a few hours. Is that the right protocol? I don't know, right? Many of these things have been just pulled out from the air saying, hey, this is convenient, let's do it. Except for, the other protocols where they really pushed to have urine flows of higher urine flows, and they used, either LVADP or LASIKs to help allow you to give more volume. I personally use the similar protocol as to what you have mentioned.
If we have time, I would like to discuss some clinical scenarios, if that's okay.
Yeah.
Although I'm usually quite confident that permanent renal damage is unlikely to result when clearing a stable CKD patient with a creatinine of, let's say, 3. For contrast, I can't help but feeling a bit anxious during the following days and sense relief when the kidney function remains stable. Can you relate to this?
Absolutely. Like I said, I do believe true CI AKI does exist, right? Especially these patients whose creatinine is 3 and 4, they have few functioning nephrons, right? So visually, if you imagine how many nephrons they have, and so there are fewer nephrons filtering the same amount of contrast dye. And that is, we are worried about it, and we do see occasionally AKI. We didn't talk about contrast dose, but I think that's the other missing aspect here, that we should really, in these kind of patients who are at high risk, mostly our cardiology colleagues are cognizant, and they will not, they will either use a smaller amount of contrast, they will not do a left ventriculogram, but it's really important to have that conversation with them as well, that we don't really need pretty pictures, do what needs to be done and come out. Having said, sometimes the anatomy is complicated. So, it's important to get something done rather than have a non-diagnostic scan. Also, that's the flip side to it. The other aspect is the repeat procedures, right? So sometimes you will do a diagnostic and then it will be followed by a therapeutic procedure. So I think it's important to make sure, unless, it's really vital, someone's in shock or what have you, that you make sure that the patient has cleared that first contrast dose before you get that second contrast dose.
I was quite surprised to read Mehran's updated risk score in last year's Lancet, where the authors state that the addition of procedural variables like contrast volume did not really increase discrimination. So it's all kind of non-modifiable risk factors, it appeared, and even contrast volume did not really cause a big change in the rates of acute kidney injury.
Right. So if you look at the definition, it is a CA-AKI, and it is the KDIGO-1 kind of, soft AKI. So I honestly, I wonder how much of it was true contrast-induced AKI, right? I would say they should use, and that's the whole literature, right? That's why you really need good adjudication. If otherwise you will just have noisy AKI, and your research studies will be influenced because of that. The better study, I personally, in terms of risk score, Mehran's risk scores are the ones that are the most famous. But the one that was externally validated is from Sai, from Duke, it's the NCDR risk score. I personally prefer that. And it also gives you a risk of AKI, but also a risk of dialysis. And when you're talking to a patient, I think that second risk is more important, right? Because if I tell them, hey, your risk of creatinine bump is 10%, but your risk of dialysis is 1%, I think, Gunnar's patient will be more likely to say, okay, then I'll go ahead and I'll get the contrast. If you say 10% or 20% AKI, which is a creatinine bump risk score, that's less useful. You don't want to have that guide your decision making.
This is a very important point, and that was actually a question I wanted to ask you, if what you tell the patient if you see him or her prior to the procedure with an advanced stage of kidney disease. Obviously, it needs to be addressed that the risk is there, although it is not as big as widely believed.
Exactly. So I do not say that it is a myth for sure. And again, if the patient really needs a procedure or they need an imaging, you bite the bullet and do it. You explain the risk, of course, and I have used the NCDR risk score sometimes to have the conversation so that we have shared decision making, because ultimately it's the patient making the decision. But we are doing these scans for a reason. We are not doing them because we want to have nice pictures. We are doing them either for obtaining a diagnosis. It may be we are missing liver cancer or what have you by not giving the contrast. I think that is just as important, or perhaps more important, than the kidney injury which is going to occur. And we will miss, of course, even if I use this risk scores, and I do believe, as you said, that true contrast-induced AKI almost always recovers. But especially if it's an arterial procedure, they may develop atherembolic disease and they may not recover, right? So there is that low risk that they may get AKI and that AKI may not recover. So you don't want to be blasé also and say that, you'll be fine, just do it. The risk is probably low, it is true. But when the benefit that you're getting from either, diagnostic or therapeutic point of view is important, then, that's what I use to have the discussion.
I mean, sometimes there are situations where there are competing or multiple risks, like the patient who has had abdominal surgery, develops acute kidney injury, has rising inflammatory markers, borderline blood pressure, and you are worried about some intra-abdominal pathology. And you really would like to do a contrast-based exam, but radiologists are understandably reluctant to concur. And I think it depends very much on your local radiologists, whether you get your scan or not. We are fortunate in our hospital, we could convince our colleagues if the indication is clear and we don't need dialysis afterwards. I think that's an issue which we're going to discuss a bit later. I think that's a very important point to make. Perhaps this brings me to my final question. Surely we as nephrologists, what should we do to educate our colleagues, especially radiologists or cardiologists, about the much smaller risk of contrast than widely believed? You mentioned the term renalism, denying patients an indicated contrast-based investigation because of an exaggerated fear of kidney injury. What needs to be done without running the risk of being too liberal, ending up in complete kidney ignorance like in the old days? This is a small path, I think.
Yeah, exactly. So, and the patient that you mentioned with intra-abdominal bad things going on, I would, push to get a contrast CT done. Forget about the kidney. The patient may die. That's way more important than, some creatinine bump. And again, the other thing you mentioned about that you have been able to convince your radiologist locally, and that is the key, really. There is nothing else. You can, rather than dictate terms, which doesn't work. What we did locally was the same thing. We had a bunch of meetings with each other, and we sat down at a table and said, as nephrologists, we are not going to blame you, right? None of us are going to blame you if something bad happens. Please don't do this. Please go ahead and give the contrast if it is appropriate. We still have the occasional, somebody who has not kept up and who will get scared. You have to make sure the technologist, the technicians involved also are aware, because, like last week, it still happened at my institution. I had ordered the CT, someone who had peritoneal carcinomatosis. And they went in and I had said, please give contrast. We did not know the primary, and I had written, please give contrast. It's a nephrologist ordering. It turns out at the table, the technician saw the creatinine. They called some radiologist who was, somewhere else on the phone. They said, this is the creatinine. They said, okay, don't give the contrast. So we had a non-diagnostic CT scan. This is rare, of course. I'm bringing it up because my blood pressure went up as soon as I saw that. So we just have more conversations. Really, there is no other way. You talk with your colleagues and you bring them, and you, as radiologists, I can understand that, right? They are the ones who are injecting a nephrotoxin, a potential nephrotoxin. Some clinical injury may happen, and they feel responsible that they have caused it. And no disrespect intended, but they often don't take care of patients, right? They are not clinicians in the regular sense. So they are afraid, and there is all the medical legal liability, all those kind of concerns, which are more in some jurisdictions than others. So there is no other way out except, having these conversations again and again. It's the old-fashioned way of talking to your colleagues and trying to solve the problem that way.
I was quite impressed by the joint US ACR NKF statement 2 years ago. I think that's the way to go also in Europe.
Exactly right. Yeah, it was a joint kind of a statement, right? When nephrologists, radiologists came together, and we are doing something similar as we are updating the Canadian guidelines. And it's really good to have us at the table saying to be permissive, saying, please give contrast. And even for us in the nephrology community, we should do it. Sometimes my fellows will do it, right? They will see a CT, contrast, AKI, they will say, oh, it's contrast AKI, right? So we should stop saying that. And I often correct my trainees saying, please stop doing this. Please stop blaming the contrast for everything.
So I would like to conclude this really fascinating talk by 2 or 3 final questions. The first one would be, we already alluded to this in some parts. We still read about stopping ACE inhibitors, ARBs, and diuretics before giving contrast media. So I'm rather reluctant to do so, because I always see people leaving hospital without anybody reinitiating ACE inhibitors and ARBs. What are your ideas on that?
Yeah, so there is the theoretical, discussion about what happens with ACE inhibitors at the renal afferent arteriolar level. But if you look at the trial data, there is actually a trial by Rosenstock, which looked at people who were on ACE inhibitors, ARBs, and they were randomized to stopping or not stopping. They saw no difference, right? And that's the story with all of these, that you may develop a lot of biological explanations and all that. But when you look at empiric data, it doesn't support stopping ACE inhibitors or ARBs. Yes, if your patient is hypotensive, you should stop ACE ARBs. Yes, if your patient is volume contracted, then stop the diuretic, but do it for a clinically valid reason. Don't do it to decrease your risk of AKI. You're absolutely right that once you stop, some of these patients, they don't get restarted, and they're missing the benefit of being on an ACE inhibitor or an ARB or a diuretic in the long run. Probably a Flozin also, right? SGLT2 inhibitors will also, they're in the sick day rules. So we should be careful not to stop medications which are useful just for preventing, a risk factor which is so low.
So then what about dialysis after contrast applications? So 20 years ago, we had a couple of studies that clearly showed that in people not on dialysis, there's no benefit if they have dialysis directly after contrast media. When you have a dialysis patients who say undergoes dialysis treatment on Mondays, Wednesdays, and Fridays, do you try to kind of choose a date for the contrast media application very short before this dilated session?
Yeah. So there are two aspects to this. One is in patients who have residual kidney function, especially if they are not on hemo, if they're on peritoneal dialysis. But even if on hemo, we know residual kidney function is like such a important predictor of long-term outcomes. So if I believe that contrast causes AKI in those with GFR less than 30, especially, then those with residual kidney function are in the severest category of getting that injury. But if we look at the data, and again, this is very, these are observational studies, not great quality data, but we did a systematic review published in Nephron a couple of years ago. It doesn't seem to do so. So giving contrast doesn't seem to affect the residual kidney function that much, especially when you look at longer term data. So there may be some blips and some small effects, but in the longer term, it doesn't seem to affect the residual kidney function. If there is a concern of volume, sometimes they get a large amount of volume, maybe then the dialysis aspect may need to be coordinated. But otherwise, I don't worry too much about it. In terms of whether doing dialysis prevents some damage, I don't believe it's possible. If the contrast is going to cause damage, it does that in 1 or 2 cardiac cycles, right? Removing the contrast 6 hours later, 4 hours later is not going to help. The only reason to look at this aspect about the timing is in case you're concerned about volume overload with the amount of volume they might be getting. Otherwise, I don't usually bother.
And then my final question. So we talked a lot about overdiagnosing contrast media induced AKI. Do we underestimate the risk of atherosclerotic disease, which may happen after catheterization?
Absolutely. I think all the, I don't know how much, it would be nice to have biopsies or some non-invasive way of making those kind of diagnoses, right? We look at feet and we look at markers of cholesterol emboli elsewhere, which are not very sensitive. I always suspect, those patients that were labeled as contrast AKI but never recovered, they were probably atherosclerotic disease, right? I'm confident that we underdiagnose atherosclerotic disease. There is, the other literature I mentioned with atheroma volume that seems to suggest a bunch of these are actually cholesterol emboli. Yeah, that's absolutely accurate. We overdiagnose contrast AKI, contrast-induced AKI, and we underdiagnose cholesterol emboli and atherosclerotic kidney disease.
So thanks a lot. This was really fascinating. I think it was a great tour d'horizon across all aspects of contrast media, and I say associated, not induced, AKI. Thanks a lot for being with us. So it's Groundhog Day today. When we're recording, I saw that you are ahead of a very cold winter weekend in Canada. Hopefully spring will come soon to you. Thanks for all the work you did in the past and looking forward to meeting you once again in the future. Thanks a lot.
Thank you. Thanks for having me.
Bye-bye.
Bye.